Hello, class. Welcome to Flourish Nursing Academy. This is Tutor Godwin. Let's look at conjunctivitis. The conjunctiva is a thin membrane that covers the inner surface of the eyelid and the white part of the eyeball. Conjunctivitis is the inflammation of the conjunctiva. Inflammation of the conjunctiva is called conjunctivitis, which makes the white of the eye appear red. Conjunctivitis, also known as pink eye, is an inflammation or infection of the transparent membrane, conjunctiva, that lines the eyelid and covers the white part of the eyeball. When small blood vessels in the conjunctiva become inflamed, they're more visible. This is what causes the white of the eyes to appear reddish or pink. Causes of conjunctivitis: viral conjunctivitis, adenovirus, HSV, bacterial conjunctivitis, Staphylococcus aureus, Streptococcus pneumoniae, Haemophilus influenzae, Chlamydia trachomatis, allergic conjunctivitis, pollen, perfumes, cosmetics, smoke, dust. Chemical conjunctivitis, acidic and alkaline risk factor. Exposure to something for which the person has an allergy, allergic conjunctivitis. Exposure to someone infected with the viral or bacterial form of conjunctivitis. Using contact lenses frequently, microbial infection, chlamydia, fungus. Types: conjunctivitis is viral and bacterial conjunctivitis. Viral conjunctivitis and bacterial conjunctivitis may affect one or both eyes. Viral conjunctivitis usually produces a watery discharge. Bacterial conjunctivitis often produces a thicker yellow-green discharge. Both viral and bacterial conjunctivitis can be associated with colds or with symptoms of a respiratory infection, such as a sore throat. Allergic conjunctivitis. Allergic conjunctivitis affects both eyes and is a response to an allergy-causing substance, such as pollen. Most allergic conjunctivitis can be controlled with allergy eye drops. Toxic conjunctivitis. Toxic conjunctivitis typically occurs with constant use of topical ocular medications. The reaction may take days to years to develop. There also appears to be a dose-response effect of the preservative concentration and the total amount of preservative-containing medications used. It implies direct damage to ocular tissues from an offending agent, usually a preservative or medication. Pathophysiology. Microbes enter the eye on contact with infected objects, inflammation of the eye, dilatation of blood vessels of the eye, swelling, redness, exudates, and discharge. Sign and symptoms: tenderness of the eye or pain, which can be severe in the cases of irritant conjunctivitis, and swelling of the conjunctiva, chemosis. Itchiness, body aches, photophobia, redness of the eye or inner eyelids, hyperemia, discharge and tear, epiphora. Drooping of the upper eyelid, periorbital cellulitis, fever, sore throat, runny nose, swelling of the eyelids. Infection usually begins with one eye, but can quickly spread to the other eye in cases of viral or bacterial conjunctivitis. Diagnostics tests: history collection, physical examination, culture of secretions, conjunctival scrapes for cytology, rarely done, and detecting chlamydial and fungal infections. Conjunctival incisional biopsy, medical management. The management of conjunctivitis depends on the type of conjunctivitis. Most types of mild and viral conjunctivitis are self-limiting, benign conditions that may not require treatment and laboratory procedures. Bacterial conjunctivitis. If the infection is bacterial, the doctor may prescribe antibiotic eye drops as pink eye treatment, and the infection should go away within several days. Antibiotic eye ointment in place of eye drops is sometimes prescribed for treating bacterial pink eye in children. An ointment is often easier to administer to an infant or young child than eye drops, though the ointment may blur vision for up to 20 minutes after application. With either form of medication, expect signs and symptoms to start getting better in a few days. Topical antibiotics: fluoroquinolones, sodium sulfastamide, or trimethoprim for 7 to 10 days. Viral conjunctivitis. There is no treatment for most cases of viral conjunctivitis. Instead, the virus needs time to run its course, up to 2 or 3 weeks. Viral conjunctivitis often begins in one eye and then infects the other eye within a few days. The signs and symptoms should gradually clear on their own. Antiviral medications may be an option if the doctor determines that the herpes simplex virus causes the viral conjunctivitis, is allergic conjunctivitis. If the irritation is allergic conjunctivitis, the doctor may prescribe one of many different types of eye drops for people with allergies. These may include medications that help control allergic reactions, such as antihistamines, or drugs that help control inflammation, such as steroids and anti-inflammatory drops. The patient may also reduce the severity of allergic conjunctivitis symptoms by avoiding whatever causes the allergies when possible, lifestyle and home remedies. Apply a hot compress to the eyes. Try eye drops. Stop wearing contact lenses, reduce exposure to light, and prevent rubbing of the eye. Clean the eye using sterile water and cotton swabs from the inner canthus to the outer canthus. Use of dark sunglasses is advised in the presence of photophobia. Prevention. Practice good hygiene to control the spread of pink eye. For instance, don't touch your eyes with your hands. Wash your hands often. Use a clean towel and washcloth daily. Don't share towels or washcloths. Change your pillowcases often. And don't use eye cosmetics. Don't share eye cosmetics or personal eye care items. Although pink eye symptoms may be resolved in 3 or 4 days, children with viral conjunctivitis may be contagious for a week or more. Children may return to school when they no longer experience tearing and redness of the eyes. Red flags requiring urgent ophthalmology referral: moderate to severe eye pain, marked photophobia, decreased visual acuity, or new blurring. Corneal opacity ulcer, irregular pupil, severe headache with nausea, vomiting, possible angle closure glaucoma. Contact lens wearer with pain or photophobia, risk of bacterial keratitis, pseudomonas. Suspected herpetic eye disease, dendritic lesions, vesicles on eyelid, tip of nose. Hyperacute purulent discharge, suspected gonococcal. Chemical burns or penetrating abrasive trauma. Periorbital orbital cellulitis signs, fever, proptosis, and painful or limited eye movements. Neonates with infectious conjunctivitis. Common nursing diagnoses: risk for infection transmission related to contagious ocular secretions. Acute discomfort, pain related to ocular inflammation. Deficient knowledge related to the disease process and infection control. Risk for injury, corneal involvement related to inappropriate treatments or contact lens use. Disturbed body image or social interaction, school exclusion. Infection control and home care. Strict hand hygiene before, after eye contact. Avoid touching, rubbing eyes. Use separate towels, linens. Do not share cosmetics. Discard eye makeup and replace after resolution. Replace or disinfect contact lenses and cases. Avoid contacts until fully resolved and 24 to 48 hours after finishing antibiotics, if bacterial. Clean frequently touched surfaces. Viral conjunctivitis can remain contagious for 7–10 days. Medication and symptom management. Bacterial conjunctivitis, topical antibiotics per order. Examples include erythromycin ointment or trimethoprim polymyxin B drops. Fluoroquinolone drops, preferred in contact lens wearers due to pseudomonas risk. Warm compresses 3 to 4 times daily to loosen crusts. Gently cleanse lids from inner to outer canthus with a clean, warm, damp cloth. Improvement expected in 24 to 48 hours. If no improvement or worsening, reassess. Viral conjunctivitis, supportive care only, cool compresses, artificial tears, oral analgesics, acetaminophen, NSAIDs as appropriate. Antihistamine mast cell stabilizer drops may help symptoms. Avoid topical antibiotics unless bacterial superinfection is suspected. Educate on high contagion. Stay home if unable to avoid close contact or control secretions. Return when improving and able to maintain hygiene. Allergic conjunctivitis, allergen avoidance, cool compresses, avoid eye rubbing. Antihistamine mast cell stabilizer drops is ordered. Oral antihistamines if needed, lubricating drops. For chronic severe forms, vernal atopic, coordinate with the provider. Avoid topical steroids unless prescribed by ophthalmology. Hyperacute gonococcal, Emergency, immediate ophthalmology ED, saline irrigation, systemic therapy e.g. IM, IV ceftriaxone, and topical care per protocol. Evaluate, treat sexual partners. Chlamydial, systemic antibiotics, azithromycin or doxycycline per provider. Counsel on STI screening, partner treatment. Chemical exposure, immediate copious irrigation with normal saline or water for at least 15 to 30 minutes. Remove contact lenses, check ocular pH if available, and continue irrigation until neutral. Urgent ophthalmology evaluation. Pain control, use systemic analgesics as appropriate. Do not use topical anesthetic drops at home, risk of corneal injury and delayed healing. Avoid eye patching in infectious conjunctivitis, promotes bacterial growth. Avoid topical corticosteroids unless directed by ophthalmology, risk of corneal thinning, worsening herpetic infections, elevated IOP. Contact lens specific guidance. Immediately stop lens wear with any redness or pain in your eye. For confirmed or suspected bacterial conjunctivitis in lens wearers, anticipate fluoroquinolone drops per order and urgent evaluation for keratitis if pain photophobia is present. Replace lenses, case, and solution after recovery. Review proper lens hygiene. Patient and family education. How to apply eye medications. Wash hands. Avoid touching the dropper tip. Pull the lower lid to form a pocket. Instill a drop without touching the eye. Close the eye gently and perform punctal occlusion for 1 to 2 minutes to reduce systemic absorption.